Welcome to our second and last video on glomerular diseases. We will talk about mixed nephritic and nephrotic syndromes. Let's begin. In the second half of this lecture, we'll discuss the syndromes that can present with characteristics of nephritic and nephrotic syndromes. We'll review the characteristics of both nephritic and nephrotic syndrome before discussing the diseases that can present with this mixed picture, which are diffuse proliferative glomerulonephritis and membranoproliferative glomerulonephritis. Before we discuss pathologies in this lecture, let's review characteristics of both nephritic and nephrotic syndrome, since they can both come into play in these pathologies. If you haven't watched our nephritic and nephrotic syndrome lectures, make sure to check those out for more details and a complete understanding of the glomerular pathologies. Let's start with nephritic syndrome. Nephritic syndromes may present with some edema, but it usually will not be as severe as nephrotic syndrome, since there is less protein being spilled into the urine. The proteinuria in nephritic syndromes will be less than 3.5 grams per day. However, nephritic syndrome will present with significant hematuria and may have red blood cell casts in the urine. Finally, since there is less protein being spilled in nephritic syndrome than in nephrotic syndromes, the serum albumin is typically normal. Now let's take a look at nephrotic syndrome. In nephrotic syndrome, the edema is usually significant due to the amount of protein being spilled in the urine. Remember that nephrotic range proteinuria is greater than 3.5 grams of protein in the urine per day, in contrast to nephritic syndrome. Nephrotic syndrome will rarely have hematuria and will typically have fatty casts rather than red blood cell casts. Finally, due to the amount of protein being spilled in the urine, the patient's serum albumin will be low in nephrotic syndrome. Now that we have reviewed the characteristics of nephritic and nephrotic syndrome, let's take a look at the pathologies that have overlap between these two. Let's start with diffuse proliferative glomerulonephritis. We'll cover definition, pathophysiology, clinical presentation, diagnosis, and management. Diffuse proliferative glomerulonephritis is the nephritic syndrome due to immune complex deposition on kidneys. It's commonly associated with systemic lupus erythematosus. In fact, diffuse proliferative glomerulonephritis is also known as type 4 lupus nephritis. In patients with systemic lupus erythematosus, the anti-double-stranded DNA antibody binds to double-stranded DNA, forming immune complexes, which is a type 3 hypersensitivity reaction. These immune complexes then deposit on the kidneys and can lead to complement-mediated inflammation. Typically in these patients, the level of the anti-double-stranded DNA titer correlates with the severity of the kidney disease. Let's solidify this pathophysiology with this illustration. The patient with systemic lupus erythematosus commonly develops anti-double-stranded DNA antibodies. These antibodies bind to double-stranded DNA, forming immune complexes. Immune complexes then deposit in the kidneys, causing complement-mediated inflammation. It's high yield to know that the anti-dsDNA titer correlates with the severity of diffuse proliferative glomerulonephritis. Let's talk about the clinical presentation of the diffuse proliferative glomerulonephritis. First, the patient typically has signs and symptoms of systemic lupus erythematosus like a malar rash, joint pain, and cytopenias. Signs and symptoms characteristic of the diffuse proliferative glomerulonephritis include hypertension, dark urine, and oliguria or anuria in severe cases. Diffuse proliferative glomerulonephritis commonly presents as a mixed picture of nephritic and nephrotic syndrome. So the patient will have signs of nephritic syndrome such as hematuria along with 24-hour urine protein excretion greater than 3.5 grams, which can lead to things like edema and serum hypoalbuminemia. Let's talk about diagnosis. A 24-hour urine protein excretion rate is usually less than 3.5 grams. However, as we mentioned before, diffuse proliferative glomerulonephritis can present as nephritic nephrotic syndrome with a protein excretion rate more than 3.5 grams per day. A patient's urinalysis will typically be positive for both blood and protein. Since the immune complexes that deposit in diffuse proliferative glomerulonephritis activate complement, the patient's serum C3 complement levels will be low. A patient's creatinine may or may not be elevated and is more likely to be normal in early stages of the disease. Patients may also develop hypertension secondary to their kidney disease. Renal biopsy confirms the diagnosis of diffuse proliferative glomerulonephritis. Light microscopy typically shows the wire looping of glomerular capillaries. This is due to thickening of glomerular capillary walls. Immunofluorescence will show the granular pattern due to immune complex deposition. Finally, electron microscopy reveals the subendothelial or intramembranous deposits. This is the light microscopy image of the patient with diffuse proliferative glomerulonephritis. You can see these wire loops characteristic of this condition. This is the immunofluorescence image of the patient with diffuse proliferative glomerulonephritis. You can appreciate the granular pattern of the fluorescence due to immune complex deposition. This is the electron microscopy image of the patient with diffuse proliferative glomerulonephritis, and you can see the subendothelial immune complex deposits right under the glomerular endothelial cells. Management of diffuse proliferative glomerulonephritis includes systemic corticosteroids and mycophenolate, Mofetil, or cyclophosphamide. A 30-year-old woman presents with red urine, bilateral leg swelling, and hypertension for the last 2 weeks. She has diffuse joint pain and bilateral facial rash involving the cheeks. Complete blood count reveals pancytopenia. Renal biopsy confirms type 4 lupus nephritis. Which antibody correlates with the severity of this patient's renal condition? This patient presents with red urine, bilateral leg swelling, and hypertension. This presentation is consistent with the nephritic syndrome. She has diffuse joint pain and bilateral facial rash involving the cheeks. All these findings suggest the diagnosis of systemic lupus erythematosus. The renal biopsy confirms the type 4 lupus nephritis, which is another name for diffuse proliferative glomerulonephritis. It's high yield to remember that the anti-double-stranded DNA antibody titer correlates with the severity of type 4 nephritis. This is because the renal deposition of anti-double-stranded DNA antibody along with the antigen causes nephritic syndrome. Now let's move on to membranoproliferative glomerulonephritis. Here is our overview slide of topics we'll discuss for membranoproliferative glomerulonephritis. Membranoproliferative glomerulonephritis is a pattern of glomerular injury characterized by increased mesangial hypercellularity and thickening of the glomerular basement membrane. This pattern of injury is often associated with infections of autoimmune processes and is also known as dense deposit disease. It commonly presents as nephritic nephrotic syndrome. In other words, the patient has the signs of nephritic syndrome, but the 24-hour urine protein excretion rate is more than 3.5 grams. These are the two types of membranoproliferative glomerulonephritis, type 1 and 2. Let's discuss the pathophysiology of type 1 membranoproliferative glomerulonephritis, which is very similar to that of other nephritic syndromes we have discussed so far. Certain infections like hepatitis B and C include antibody production against the microbial antigens. These antibodies then bind to antigens, forming the immune complexes. Immune complexes deposit in the kidneys, causing complement-mediated inflammation. Let's move on to type 2 membranoproliferative glomerulonephritis. Type 2 membranoproliferative glomerulonephritis is characterized by C3 nephritic factor. C3 nephritic factor is an IgG antibody that stabilizes the C3 convertase. C3 convertase in turn causes persistent activation of the complement pathway, which leads to inflammation and kidney injury. Here's the illustration showing the pathophysiology of type 2 MPGN. As we already explained, C3 nephritic factor stabilizes C3 convertase. C3 convertase then cleaves the C3 and activates complement cascade, resulting in inflammation. The clinical presentation of the membranoproliferative glomerulonephritis is identical to that of other nephritic syndromes, but may also have symptoms of nephrotic syndrome as well. Sodium and water retention causes hypertension and peripheral and periorbital edema, especially in the context of spilling protein and albumin due to nephrotic syndrome. Dark urine, on the other hand, is due to hematuria. Let's talk about diagnosis. A 24-hour urine protein excretion rate is usually less than 3.5 grams. However, as we already explained, membranoproliferative glomerulonephritis can present as nephritic nephrotic syndrome with protein excretion more than 3.5 grams per day. Urinalysis will typically be positive for both blood and protein and may also have red blood cell casts. The creatinine may be normal or elevated in these patients. Finally, persistent activation of complement in membranoproliferative glomerulonephritis leads to hypocomplementemia. Light microscopy of the renal biopsy specimen typically shows the tram-track splitting of the glomerular basement membrane. This happens due to mesangial ingrowth into the glomerular basement membrane. Immunofluorescence will show a granular pattern due to immune complex deposition. Finally, electron microscopy in type 1 membranoproliferative glomerulonephritis shows subendothelial deposits. In contrast, the electron microscopy in type 2 membranoproliferative glomerulonephritis shows intramembranous deposits. This is why the type 2 membranoproliferative glomerulonephritis is also known as dense deposit disease. This is the light microscopy image of the patient with membranoproliferative glomerulonephritis. You can see the mesangial ingrowth into the basement membrane, creating the tram-track sign. This is the electron microscopy image of the patient with type 1 membranoproliferative glomerulonephritis. Please note the subendothelial immune complex deposits characteristic of this condition. And here you see the electron microscopy image of the patient with type 2 membranoproliferative glomerulonephritis. Please note the intramembranous immune complex deposits right in the center of the glomerular basement membrane. Now let's talk about management. First, one should treat the underlying infection in type 1 membranoproliferative glomerulonephritis. Additionally, systemic steroids and mycophenolate mofetil should be administered in patients with significant proteinuria and/or abnormal kidney function. ACE inhibitors can be used to reduce proteinuria and manage hypertension. They also delay progression of nephritic syndrome. A 55-year-old man presents with dark urine and hypertension. He has the past medical history of intravenous drug use in his 30s. The physical exam reveals periorbital edema and bilateral leg swelling. Renal biopsy shows mesangial ingrowth in the glomerular basement membrane with subendothelial immune complex deposits. C3 nephritic factor is negative. Which two microbes can cause this patient's current condition? This patient with a history of intravenous drug use presents with dark urine and hypertension. Renal biopsy shows mesangial ingrowth in the glomerular basement membrane with subendothelial immune complex deposits. C3 nephritic factor is negative. All these findings are consistent with the diagnosis of type 1 membranoproliferative glomerulonephritis. Hepatitis B and C can cause type 1 membranoproliferative glomerulonephritis. Here is a summary table of the nephritic nephrotic syndromes that we discussed in the lecture. Pause the video and take a moment to consider this table. A 35-year-old white woman presents to the physician reporting red urine and bilateral leg swelling for the past week. Her past medical history includes hydralazine-induced lupus that resolved after drug discontinuation. She's an active heroin abuser. Her vital signs include a temperature of 36 degrees Celsius, blood pressure of 160/95, heart rate of 80, and respiratory rate of 16. Her BMI is 32. The physical exam reveals 2+ bilateral pitting edema. Urinalysis is significant for 150 red blood cells per high power field, along with red blood cell casts. A 24-hour urine protein excretion is 5 grams. C3 nephritic factor is positive. Renal biopsy is performed to confirm the diagnosis. Which of the following findings is most likely to be expected on the electron microscopy of the biopsy specimen? A. Effacement of podocyte foot processes. B. Spike and dome subepithelial deposits. C. Mesangial ingrowth and GBM splitting. Or D. Wire looping of capillaries. This patient presents with red urine and bilateral leg swelling for the past week. Her vital signs are significant for hypertension with a blood pressure of 160/95. Physical exam reveals 2+ bilateral pitting edema. Urinalysis is significant for 150 red blood cells per high power field along with red blood cell casts. All these findings suggest nephritic syndrome. However, a 24-hour urine protein excretion that is 5 grams that falls into the nephritic range. Therefore, this patient has nephritic nephrotic syndrome. C3 nephritic factor is positive, which confirms the diagnosis of type 2 membranoproliferative glomerulonephritis. Both types of membranoproliferative glomerulonephritis are characterized by mesangial ingrowth and tram tract GBM splitting on the electron microscopy. Therefore, the correct answer is option C. Here's a summary table of the nephritic nephrotic syndromes. Pause the video and take a moment to consider this table. Let's discuss why other options are incorrect. Option A is incorrect because effacement of podocyte foot processes is characteristic of minimal change disease and focal segmental glomerulonephritis. Although this patient is obese and abuses heroin, her hematuria and red blood cell casts make pure nephrotic syndrome, like FSGS, unlikely. Option B is incorrect because spike and dome subepithelial deposits are characteristic of membranous nephropathy. Again, her hematuria and red blood cell casts make this diagnosis unlikely. Finally, option D is incorrect because wire looping of capillaries is characteristic of diffuse proliferative glomerulonephritis, also known as type 4 lupus nephritis. Although this patient has a history of hydralazine-induced lupus, drug-induced lupus rarely involves visceral organs like kidneys, and that concludes this section.